We are live in 5, 4, 3, 2, 1.
So are we live?
Yes.
Okay, so good evening, everybody. So welcome today to the third in a series of talks we are doing on pelvic and acetabular fractures. And today we are going to cover the definitive fixation of pelvic ring fractures. I'm going to talk about the anterior pelvic ring fixation, and Professor Coxon is then going to follow up with the posterior fixation of the pelvic ring. So obviously there'll be some overlap because many cases need both anterior and posterior fixation, but basically we're just going to talk about some of the techniques and indications where you need to fix these fractures. So I think hopefully by the end of this talk, you should be able to discuss the indications for anterior ring fixation, list the various options you have, describe the surgical technique, especially of symphysial plating, discuss the advantages and disadvantages of the various techniques, and also some of the newer techniques which have become popular in the last few years. Okay, I think basically for any fixation, the indication is going to be an unstable pelvic ring injury. Remembering that in the pelvic ring, the posterior part of the ring is more important and contributes to about 60% of the stability, while the anterior ring probably counts for about 40% of the stability. So the anterior injuries could be either a disruption of the pubic symphysis or fractures of the pubic rami. The pubic rami fractures could be unilateral or bilateral, or you can have combinations of both disruption of the pubic symphysis and fractures. So you need to look at this carefully before deciding on what technique you use for fixing them. We have various options, starting with external fixators, which today is mostly used for temporary stabilization. It was till some years ago often used for definitive stabilization, and still in certain circumstances where internal fixation becomes contraindicated for some reason, it may be used. The internal fixation is what would be most often used, either a symphysial plating or a plate which extends further along the column, or today we also have percutaneous screw fixation techniques and also some percutaneous plate and infix techniques, which we'll talk about. You have combinations where you can use a combination of external and internal fixation. We talked about percutaneous screws and minimally invasive techniques. Now, external fixation was a fairly safe and convenient way of stabilizing these fractures. The problem that was there in keeping the fixators for a long time was these pin side problems that you can see here, how this pin with time tends to get infected and then the pin gets loose, and you can have problems with that. You can also have loss of reduction, okay? So especially for the symphysial injury, where this is the initial X-ray, this is the fixation well reduced in the fixator, as you can see. It's, however, even if the fixator is removed 6 to 8 weeks later, there will be some loss of the reduction, often because you don't get a true bony healing here or a true fibrous healing. It gets sort of converted to fibrous tissue, but it still allows a little bit of spin back. Very rarely does it not move at all. Okay, so those are some of the problems. Now, in this particular case, that much of widening probably is not of any clinical consequence. So your indications for plating of the symphysis would be a disruption which exceeds 2.5 centimeters. As was mentioned yesterday in the talk on CTs, etc., the last week, you have to be a bit careful today, especially with the use of pelvic binders as an emergency procedure. In fact, at the site of the injury, the sort of first aid workers or the ambulance crew will put on a binder, and therefore when you x-ray them, you may not see the amount of disruption there is, or separation there is of the pubic symphysis. So sometimes it may be necessary to examine them out of the binder and take x-rays out of the binder if they're not very hemodynamically unstable. Then you can have unstable type C pelvic disruptions, where you have fractures of the pubic of the rami plus a posterior injury, and occasionally in a lateral compression fracture you will have the symphysis kind of getting locked onto that of the opposite side and tilted, where you may have to unlock the symphysis to get a reduction. Sometimes you can have a patient with a symphysis disruption undergoing a laparotomy, and that may be the most convenient time to fix the symphysis pubis as well. Sometimes for a neurological or vascular injury, fixing the fracture may be important, and this may sometimes be a rotated fragment in a lateral compression injury, where the ramus could get completely rotated and be facing front to back, and can actually cause problems with urethral injuries, vaginal injuries, etc. So you have to be careful with those and look at them carefully. And sometimes you can have a combined acetabular and pelvic injuries, where you have disruption of the pubic symphysis as well as an acetabular fracture. So we'll go through the steps of the technique. I think the approach used most often is the Fanelstein approach. If you need to go further up along the brim, then you might consider the Stopper's approach. Okay, so this is a transverse incision, usually about a couple of finger breadths above the symphysis pubis. So you feel the top of the symphysis pubis and mark out at the level of your incision. And once you've gone through the superficial tissue, fascia, you come to this sheath, which is the linea alba, which is between the two heads of the rectus abdominis. So you split in the midline, okay? And once you split the linea alba, you'll have the two heads of the rectus, which you get out of the way. And then it's important to get something between the pubic rami and the pubic bone and the bladder. So it's important to get a retractor, separate out the soft tissue. Very often this is disrupted by the injury, but you may have to separate out the soft tissue at the back, especially if they come late. And you have to be careful that you don't injure the bladder. And it's important to have a catheter in the bladder. So don't forget that before you start this procedure, you must have a catheter in the bladder. Once you get that, you very often one side of the rectus is already avulsed, but you need to dissect in front, that means of the pubic ramus. So in front of the ramus, you elevate the rectus, you don't divide the rectus, you elevate the rectus so that you get enough access, and a little more laterally so that you get to the obturator ring. Okay, so that would be, and you're able to retract the rectus adequately to put your plate superiorly. Okay, so you do that, and then the different ways you can reduce the symphysis pubis. One is to put a clamp, like a pointed reduction clamp, into the top of the obturator foramen in this superomedial corner, and then you clamp it and then you can close it. So some of these patients would have an external fixator on before surgery. So leave your pins on. You can use this to help you with your reduction. You can use the Faraboff forceps. You have to put in screws and then clamp it. Of course, if you put it on top, it will get in the way of your plates, or you may have to put an anterior plate first and then a superior plate, or the Jungbluth's forceps, which is a very useful instrument. And here you can put your screws from anterior to posterior, then use the clamp and close it. And here you can also adjust the height and to some extent rotate the fragments to get a good reduction. So this is a very useful way, and you can compress it with this and then put your plate on the superior surface of the rami. So that's how you would reduce it and fix these fractures. So just a few clinical examples. This was a young patient. You can see this got an open book type of injury. I've also had a femur fracture, which is why the shaft looks abducted there, sorry. So uh, this is to show that there's some anterior opening, but no superior uh, sort of migration of the hemipelvis. So it's a rotationally unstable, but vertically stable injury if you look at the tile classification. And here, in this particular case, we decided to just do the symphysis pubis as a young patient, quite thin, and once we got it nicely reduced, we thought it was quite stable. So there's your transverse incision. You can see the superficial tissue, the fat. You dissect it out till you get to the external oblique aponeurosis, and then that will lead you on to the sheath over the linea alba. So you can see the linea alba there, and then you split the linea alba vertically. And once you split the linea alba vertically, you can see the heads of the recti. You need to retract that, get to the back of the symphysis pubis, to the retropubic space, separate it out, put sponges, and your so there it is, that area. You can see there's some hematoma there. You separate it out, you put this retractor, ideally a malleable retractor, to retract the bladder, put sponges there to pack the posterior part so that you do not inadvertently injure the bladder. And then there you can see how you can retract the head of the rectus to get to the top of the symphysis pubis. And here we are using manual pressure to reduce it. Then we get the clamp on. That's the plate we used in this. This is a 4-hole plate. Today, more often than not, we try to use a 6-hole plate in these. And it's useful to sometimes drill your first hole before you put on the plate. So you make your drill hole and then use that to put a screw in through the corresponding hole of the plate, so that the plate sits properly where you want it and the holes correspond to where you want the screws to be. And then that's the fixation. You can see it's well reduced in the standard AP view, the inlet view, and the outlet view. And you can see if you go in the right direction, you can get fairly long screws. And this direction, your finger at the back of the pubic bone will help you get the direction of the screws. So you have to drill parallel to your finger so that you don't come out of the pubic bone posteriorly or anteriorly. And then you can get fairly long screws. In Indian patients, it's 50, 55, sometimes even 60 millimeter screws you can get to get a nice hold on the bone that is there in the front of the pubis. So here showing a clamp to reduce it and fix it. We are using a 6-hole plate. Again, the corresponding view showing the reduction. Now, if you don't have this symphysis plate, there are other options. The reconstruction plate is one we can use, or we sometimes actually use a simple DCP, but we tend to bend it a little bit, curve it the way the symphysis pubis plate is curved, using the lateral bender to get the shape right so that the screws go in the right direction. So there's one where we use a fixation in the front using a standard. This is actually a locking compression plate and a posterior sacroiliac screw on the same side. So here's another patient. Again, you can see an open book type of injury. You can see there's sacral fracture on the left side here. There's a sacral fracture. And here, what we did was we used a symphysis plate in the front, and posteriorly we used this percutaneous rod technique, like a tension band, where we put in the pedicle screws into the iliac crest, and I'm sure Dr. Kong will talk on in more detail about it. But you can see the anterior fixation again, how the ring is nicely reduced and fixed using this technique. And this is a follow-up to show everything has gone up to heal all right. Now, sometimes when you have these combination injuries, so you can see that there's a disruption of the pubic symphysis, but you also have a rami fracture close to the acetabulum. Now, you can, there are different ways to tackle it. You can plate this and put a percutaneous screw for that, or you have to extend your plate sort of laterally. In this particular case, what we did was actually extend the plate across to the opposite side here to fix the symphysis, and more to along the brim, more laterally to fix the fracture there, so that we got a good stable fixation. And this is just to check all the views that we've got a good reduction and fixation as well. There's some debate about whether you should use a single plate or a double plate. I think in most unstable type of open book types of injuries, usually one plate is enough. Today we tend to use a 6-hole plate rather than a 4-hole plate, but it's important to get these long screws, and if you can put them in slightly different directions, it helps in getting a better stability. Now, some osteoporotic bone, you may need double plating, and in some of the old fractures where you're treating a late presentation with a pubic symphysis disruption, where double plating may be important. And some very unstable fractures, like in this case, you can see there's crescent type of fracture posteriorly, opening of the pelvis plus a vertical displacement. And here, although we plated it posteriorly, put a lag screw across the crescent fracture and put a plate in front, and the reduction looks okay. Unfortunately, with time, you can see how the anterior fixation kind of gave way or sort of moved a little bit. And so we ended up having to remove this implant. We didn't have to do any further surgery because the patient was relatively asymptomatic. Now, we talked about percutaneous screws for fixations and combination external fixator and internal fixator. So sometimes if you want to avoid putting a posterior screw for whatever reason, it could be sacral dysmorphism where putting a SI screw may be difficult, or a Morel Lavelli lesion which you don't want to go through to put in your screws. A combination of a plate and an external fixator gives you extra stability and protection of any sort of fixation that you might have which you're worried about. So here's a case where we did that. We used the plate, but we also left the fixator on to give adequate sort of protection for the plate, and this went on to heal well. We talked about this transpubic screws. Now this can go either retrograde from the sort of distally to proximally, or you can put it an anterior column screw type from the proximal part to the distal part. So here you have to start fairly medially, so almost at the and inferiorly to get the right direction. And you need your obturator view as well as your inlet view when you're doing this so that you can see the direction of your screw so that you get a good fixation. So here's a case again, there was a posterior sacral injury on this side and fracture of the pubic rami there, and you can see we've got 2 screws in the SI joint in the S1 level, and we got this 6.5 lag screw starting from here. Now in Indian patients, it's not always possible to put a 6.5 screw. Sometimes we have to make do with 3.5 screws, but if you can get a 6.5 screw, it's obviously much more stable and much stronger. So that's one example. Here's another example where we put a sort of a 3.5 screw, but here we protected it with an external fixator. Now, just a few words of the minimally invasive techniques that have come about recently, and this is from Dr. Peter Cole, who had come here for an MIO, a minimally invasive course many years, and he's one of the people who pioneered this technique of putting a plate percutaneously from one iliac crest to another with screws in the region of the symphysis. So you can put this screw all the way across the plate, slip the plate percutaneously, but this has its own sort of sets of complications. You have to be careful of neurovascular damage when you're sliding these plates. So you have to learn your anatomy well and learn the technique well before you try it. And these are again slides from him showing how you can fix it unilaterally or bilaterally depending on the situation. The other technique is that of what we call the infix which just as I showed you the technique of using pedicle screws posteriorly on the iliac crest and putting a rod across, where you can do it anteriorly, where you put your screws where you would put your supraacetabular pin. So you need to have long screws, long pedicle screws. And also you can't put these screws all the way in. So you have to keep these screws out a little bit. Otherwise you are in danger of having compression on the femoral nerves and the neurovascular structure. So be careful about how that you have to keep it out a little bit. And therefore in a thin patient, it becomes a problem because it can be sort of fairly prominent. So probably reserve this for more obese patients where you want to avoid surgery for whatever reason, either because he's had a suprapubic catheter in or whatever reason you want to avoid putting a symphysial plate in. So I think overall the advantages of internal fixation are in obtaining and maintaining reduction. It's a biomechanically stable fixation. It allows you early mobilization and overall has better outcomes. And today you have safer techniques which make it possible. You also have these minimally invasive techniques. You also have better imaging, and in certain centers they're using navigation for the percutaneous screws. The advantages are obviously every surgery has its own complication. You need to make sure that you don't cause any damage to the bladder when you're doing the or the urethra when you're doing a suprapubic symphysial plate. Infection is of course a complication that you have to be aware, and you can get failures of fixation if your fixation is not adequate. So I think take-home message is that open reduction and internal fixation of the anterior ring is an advantage in the definitive management of these fractures. Remember that 40% of the pelvic ring stability comes from the anterior ring. So it is often important to fix this as well. And whenever you do this, it's important that you plan your technique carefully and also learn the surgical techniques adequately so that you avoid complications when you are doing your surgery. So thank you very much, and I'll hand over, we'll have the questions and then hand over to Dr. Tong for the fixation of the posterior ring. Okay, so also, of course, you have to be aware of potential complications.
So, we have few questions in the chat box, sir.
Sure.
The first one is asked by Dr. Gautam that what is the post-operative protocol after the fixation?
So I think your aim of fixation is always to try and mobilize the patient, okay? Now, mobilization could mean mobilization in bed initially, depending on so these patients often have other injuries. Okay, so the pelvic fracture may not be the only injury. You may have open fractures of the tibia, femur, may have upper limb injuries. So your ability to actually walk them may vary depending on all those injuries. But if you can get good stable fixation of your anterior and posterior pelvic ring, and you don't have any other injuries in the upper or lower limb, there's no reason why you can't start them even standing on partial weight bearing mobilization as soon as possible. But at least you should be able to get them mobilized in bed as soon as possible. Okay? So that at least they can sit and do transfers, etc., as soon as possible.
And sir, the decision making, I think, is very confusing in few cases, because even sometimes just a pubic rami fracture may lead to pain if conservatively treated, and sometimes it is even type 2 APC is doing well. So how to decide that which one to be fixed, sir?
So I think your initial fixation would depend on your assessment of the stability of the ring. Okay. So if you think it's an unstable ring fracture and there are criteria like the displacement, etc., to judge the instability of the fracture, you can do clinical examination also. There's an article by Dr. Saji on this about clinical examination to look for instability. And if it's unstable, then definitely today one would go ahead and fix it, unless there is a contraindication for fixation. Okay, Coxon, please feel free to.
Yeah, I think rehab is a very important question because it depends on your work with your rehab team. So you, of course, patients may have multiple injuries. So each one has to be addressed and to see if in the whole patient they can able to weight bear if they have ipsilateral or contralateral or bilateral lower limb injuries. But the first thing to do in pelvic fracture is actually to get a level pelvis to sit. So if they can't do anything else, at least they can sit out in a bed or wheelchair, get them off their bed, start mobilizing their weight. Because many people cannot sit with an external fixator sticking up. They can't bend forward. They have to lie extended in a supine position. So getting the external fixator out and putting internal fixators helps them a lot in just starting to mobilize. They can mobilize in bed with upper limb and lower limb activities. But I think it's important that the surgeon decides how much weight there you can put, because as you have shown, even in posterior and anterior fixation, you can have the whole thing disrupted due to improper weight bearing. And if you have a heavy patient, bigger risk.
Yes, so I think the quality of bone, the quality of fixation, the hold of your, and that's something which is something that you will decide on table, okay? So you can feel how strongly your screws are holding, and if you have any doubt about it, then don't overzealous mobilization is then not a good idea. Okay, but the main aim is to at least get them sitting and moving in bed, so they're not lying in one position, which has its own problems. Okay.
Yeah, I mean, in addition to sitting up without the external fixator, they also cannot turn.
Yeah, exactly.
No, they can't turn, and the next thing you
pressure
have
sores.
sacral sore. The other thing about the stability, I'm still using 4.5 plate and screws rather than the 3.5s, because 3.5 pull-out strength is much lower, and in 4.5 plates and screws, I firstly put fewer screws and I get less risk of damaging anything inside.
Yeah,
Secondly,
I mean, certainly where you can get them, it's good. But I think with some of our patients, the bone is so thin that trying to put in 4.5 screws is really difficult. So we usually
you put in 6.5 in the Raymine.
Sorry?
You put in the 6.5 in the Raymine. So
yeah, so it depends on the patient. So that's what I'm saying. So if they have a good thick bone, yes, you can do that. But you have to judge the size of your screws based on the thickness of the bone as well. It's not always possible to put 4.5 screws.
So, and in case of combined injury, when there is both fracture of anterior and posterior ring, the one school of thought is to fix the posterior ring first, or is it like another bone like forearm bone that which is less comminuted to be fixed first, or which ones to be easily?
So I think it depends. So if you have something like an open book injury where the posterior is just a open book, so there it helps to close the book first. Okay, but if there you have a displaced posterior fracture, then always you would go to the posterior first and get that reduced, because I think getting the posterior reduced is always more important. Okay. So in a simple open book where the posterior displacement, there's no vertical displacement, you're just closing it, then fixing it anteriorly makes sense because it reduces the posterior part for you to put in your percutaneous screws. But any other situation, it's important to get the posterior reduced before you do your anterior fixation.
And so
I tend to fix both, even if it's B1 or B1.2.
Yeah, I think today
today if you see a lot of the problem is assessing the stability, and if you have you don't do a dynamic fluoro, you don't really know how unstable it is, and to rely on a small 6-hole plate sometimes because there's some translation. You may get it loosened quite fast. So I routinely err on the side of more stability by putting 2 screws at the back, or at least 1 screw.
Sacroiliac screw at the back. Yeah, so I think today we also tend to do that. Some of those cases are older cases where we And at one time, the teaching was, oh, in these open book fractures, you can just put an anterior plate if the posterior is not vertically unstable. But I think today, we'd all put a sacroiliac screws on top of your anterior fixation. No, he was asking about which you would do first, posterior or anterior. That was the question.
Usually, I do the patient supine. I intend to do that. I need to close the book. So
yeah, that's what I'm saying.
Parabol clamp or pointer reduction or Youngblood clamp, close it up, put your temporary plate with some screws, one or two screws just to hold it level, and put in your posterior screws and come and finish off the front. Because the patient doesn't need to be turned.
Yeah, but you have to do an open reduction at the back, then you do the back first.
Yeah, if you have to do that, then you have to decide to do the back and front. But the trouble with putting the patient prone. An open book, you cannot reduce it. And then when you come back to the front.
No, we are not. I'm talking about other injuries where you.
No, I'm talking about an open book. If you decide,
open book injury, usually it's the front first. Yeah.
Yeah. Vertical shear, I think, is a different kettle of fish. I think there was one question about the role of locking screw in anterior pelvic injury. I tend to shy away from locking screws, locking plates. If I have a locking plate or a combi hole plate, I usually use compression screws, not locking, because they cannot take the stress of micro motion. And you often see many 3.5 screws snap. Or
also, you have to put the screws in the direction that you need to put the screws in terms of the bones. It's very often, very rarely that the locking screw will go in exactly the right direction that you want to. So,
yes.
So even if you do add it, it will just be as a additional this thing in osteoporotic bones, but you would still have to put conventional screws to get the right direction of your screws.
Yes.
So
when you put the sleeve, when you put in the sleeve, you will know whether it's in the right direction.
Yeah.
Or you can't use the locking screw. You have to use the compression screw.
Austin, your sound is again a little muted, so.
Yeah, okay. I'll try to turn it up.
So before your talk, you need to get that.
Okay. Is it better? Is it better now?
Yeah, much better now. Yeah.
Okay.
Much better.
May I request you to share your screen, sir, so that
Yeah,
after
so I think
that
you can get.
we can take it.
Okay. My part now?
Yes.
Yeah.
Okay. All right. You've heard about the overall role of stabilization. Both parts of the broken ring have to be fixed in principle. Some are relatively stable, and if the patient is elderly or have other risks, you may decide that you may not go with a full fixation front and back. But I will talk about the fixation in the front, in the back, and what are the indications? The indications are when pelvic ring injury cannot be reduced by X-fix, and this is fairly common. So you have to be quite precise as to the definition. If you have sacral or posterior injuries with neurological deficits, it's an extension of your spinal cord and your cauda equina. You may have to do some form of decompression, and at the same time, you do some fixation. If you have combined posterior ring and acetabular fractures, you generally should fix the ring first, because if you, it's harder to fix the acetabulum when one of the two floating parts are not stable. It's not easy to reduce joint injury when the pillars are not complete. There are some basically 4 types of sacroiliac or sacral fixation. First one is the bar. You've seen it earlier. You can use it through the bone, and some people are now using internal fixators and spinal instrumentation. Then you can use the dorsal plate. You can use percutaneous iliocecal screws, or the lateral alar plates of that you only use for unilateral fractures. In principle, regarding the use of all these implants, the posterior implants offer a secure fixation by themselves in general. But if you want to do weight bearing, you need an anterior plate fixation. That's a best sort of stability. If you have a posterior fixation with an external fixator, again, it's not quite adequate for full weight bearing. So in general, if there's unstable pelvic ring fractures, I tend to go front and back. In many studies, the good strong fixation is 2 iliosacral screws and probably single or double symphysis plating depending on the screw size that as we discussed just now. Okay, now we go to the nitty-gritty. When you want to do a transverse plane stabilization, you have to put what we call iliosacral fixation. So you need to know where the SI joint, and you cannot see this SI joint if you don't look for it or you don't have a standard protocol. So this is a sort of diagrammatic picture of where the lumbosacral trunk, S1 and S2 nerves are, and you have to miss these nerves when you put in screws. If you do an open lateral approach, let's say if you're fixing an acetabular wall fracture in the SI joint, you can actually do some measurements, and what you see is it comes in this lower half of this line you draw between the crista ili and the sacral and the sliding march. And if you just put these two, they are actually where the screws will hold for S1, S2, S1 front and back, and S2 below. So these are the examples of putting the screws for these bilateral Denny 2 fractures. For surgical steps of iliosacral screws, it may be a little bit detailed, but I'll take you through it one by one. You can watch this video later to revise. The first thing is always bowel prep. You can see this picture, and often you find patients like being resuscitated. There's a lot of airbag being used and all that, and all the air goes into the bowel, and you don't really know where the bone is, and you certainly cannot see where the sacral foramina are, because they all look like sacral foramina. Preferably, you should have a radiolucent table that the spine people use. We use a Jackson table, but anything that has clearance below the buttock and lower lumbar area for you to have your C-arm positioning for your views. You must have the inlet, outlet, and the lateral view. I'll go through that in a minute. Here is a very old film in the 90s where we used to use a traction table to effect a vertical shear reduction before we put in the iliosacral screws. We were doing it this way. Then finally, you have to have some skilled arm operator. So one of the things you'll find is that you spend a lot of time trying to see what you are doing and where your drill is going, where your screw is going. And if the C-arm operator, the radiographer, who is often called just to take standard views and they're not trained, you will have a long time doing this type of surgery. So first thing to do is train your radiographer. This is the OR-C-arm positioning. I usually put a little pillow or bolster under the pillow, under the knee. That flattens the pelvis. Otherwise, you get a very low pelvis. That is a C-arm coming in from the lateral side. You get an AP view, but more important are the inlet and outlet views. So in this case of this guy who was about 400 pounds, we had to do him. He luckily got a large C-arm with a big 18-inch receiver. You get a view like this, so you can see bowel prep has been done, and you can see all the joints and the bones quite clearly for you to start your screw fixation. Then you have your outlet view, which is the other way, and then you can see the sacral foramina quite clearly. I like to see the pubic rami around the S2, so that when you put in screws, you not see screws going into below this pubic level. So this is as a marker to limit where your screws, because sometimes this may look like a foramina, this might look like a foramina. But actually, the more important view is the horizontal beam lateral, and that's how you put the beam, goes under the table. And what you want to do is to see all these screws, and especially the screw tips and heads in front, anterior to the spinal canal. So this is S1, S2, 2 screws in each one. And you can see the external fixator pins are still on while we put in these screws. You need to orientate, and this is the one part of the surgery that gets everybody confused, because there's an anterior movement, posterior movement, superior, and inferior movement. So here are some tricks. First, raise the buttock. So you get it level because the buttock very near to the table. it's hard to cleanse in the posterior area and you might get contaminated. Bring the operator side nearer to the edge where you are putting in the screw, because that will allow your hand drill to have more excursion going up and down, get your proper orientation and alignment. Then you must have a new thought of what is anterior, posterior, what is terminal and caudal. So if you draw a line where your inlet and outlet views are coming, anterior is actually anterior to this line. That means it's in this direction. Posterior here, this way, that is superior to our mind, and caudal this way, that is inferior to our mind. So you do have this superimposition, and what we have the inlet outlet projections along the plane. So that's the view that you will see as I described before. So if you start off, I always start off with a horizontal beam projection. That gives me a small drill hole. So I use a 4.5 drill it onto the lateral side of the ilium, and then leave it there and do a horizontal beam lateral. If you are in the bone, then that's your starting point. Then what you do is you try to say, okay, I want to get a bit anterior. So the anterior is not anterior this way, it's anterior and inferior, anterior and caudal. So because it's coming perpendicular to this projection. So in the view, and then you want to go inferior is actually inferior and caudal, and you're perpendicular to this outlet projection. And then similarly, if you want to go up, this will be superior into the S1, keep the beam there. And finally, if you want to do all in one, you just do a oblique, and this is the true posterior as we know in surgery. It's actually a diagonal down the bone. So this orientation is very important. There are some landmarks that you got to pick up before you do this screw. Yeah, inlet, outlet, and horizontal beam lateral view. So this is the drill that I use. Start off with 4.5 drill. I just put it on the side in an area that I think is where I want it. So you get your horizontal beam lateral, your inlet and outlet, then you can see that, okay, you are somewhere in the good area and the direction seems to be fine. Where are the landmarks? You'll see the anterior body line of S1. There is a false body line called the promontory, and sometimes they can be very prominent, and you think that that is the body. There's actually just the promontory. They're very close to the anterior sacral plexus. So try to stay, don't look for the promontory, look for body line. And what you get is an actually obliquity of the C-arm. You got to turn the C-arm, there's not always 45 degrees depending on the pelvic tilt. Okay. Then on the foramen, S1 foramen on the outlet view, S2 foramen outlet view, and your screws are going in S1 body, S2. This is the problem when you have a dysmorphism, where you have lumbarization and sacralizations of the spine, and you have to count your spine, and so use your count on your spines on the C-arm before you are sure, because this could be S2 and this could be S3. And S1 could be lumbarized, and therefore you have a nerve coming out here that is unprotected. So be careful. So if you have any dysmorphism, just go for the biggest body and just put in one screw at one level. Now the lateral, how do you read the lateral? Now this is a very important view, not in many books. The sacral outline you can see. Then you have the pelvic brim. Okay, this is a line, the density, cortical density of the iliopsoas buttress. Then you have the top of the ala surface, okay, ala of the sacrum, where the lumbosacral trunk comes down here and the ureter comes down here. Then you finish off by doing this beam shape, which is the SI joint. Then you join your S1, S2. S3 has no SI joint, so don't put any screws in S3. And you have 3 intra-articular or trans-articular screw. You can actually put a 4th screw here that is extra-articular to start with, but it will enter the body. So there are 4 screw positions. What happens if you can't, when do you need to do open reduction? Well, if you cannot reduce the SI joint closed, maybe due to delays in intervention, and then there's some malreduction, or you've taken some time to open it, to try to fix it, and you find you cannot reduce, be careful not to just put a screw this joint. If you are doing a coccolaringum back to approach the hip joint, you can actually extend the coccolaringum back Put your finger into the notch, feel the SI joint. What is important here is the superior gluteal nerve, superior gluteal artery, which is the first branch of the internal eyelid. And it comes just under this notch. And if you retract too much, or you happen to catch it in your drill bit or in your glove, you may actually tear it, and the vessel will retract inside and cause heavy bleeding. If you're doing an ilo-inguinal approach supine for the anterior or the acetabulum, you can also go into the SI joint from the front. Or if you're doing a crescent fracture like this, and you do an open reduction, you can do an open close reduction from crescent fracture. So Dr. John talked about bars and rods at the back. So just something about the rods first. They can be done open, or well, I think you've seen the picture, and then you just pass these rods. And these rods are, well, sometimes I use the Ilizarov rods and just have 2 washers on each side. You can buy it from Synthesis, but they're quite expensive. Requires a unilateral stability. Otherwise, you have obliquity, and then you don't match, and don't get reduced, and you get a ligament discrepancy. So it's only for one-sided unilateral sacral or leg injuries. You can reduce it with forceps, clamps, or leave the X-fix on and try to manipulate. Distractors can be used as well. If you want to do a neural decompression for a sacrum, you have to do it open rather than do it percutaneously. And sometimes you need to put supplementary iliosacral screws. These are all extra SI joint. They're outside the SI joint on the dorsum, and you may want to put something a little bit anterior if it's possible. Plating, there's a certain technique to do plating, originally also described and do the same incision as the rods. You reduce the clamps with either distractors, shunt screw, or some parabolic clamp to hold it, and then you put in a plate, and you bend one plate underneath the skin, pass it from here, and then secure it. And when you come to this side, you have to do in situ bending. So you need to put 2 screwdrivers there, and then alternate down into the side of the ilium. And again, supplementary SI screws can be put in for better stability. Okay, something about sacrum. Okay, there are some principles of the dorsal sacral plate. We're talking now of the pure sacral body. So if you look at the fracture coming down the Dene type 2 kind of injury, where are the safe screw positions? Firstly, between the foramen, also foramina, on the lateral aspect of the ala, and in the iliac, posterior iliac wing. So this corresponds to the pedicle. In the spine, we call a pedicle screw. Then there's the ala screw, and then you have the iliac screws. And these can be very long, 60, 70, 80, even longer than that. And then the way to do it is the pedicle screw is to find the bump there, the mammillary body, and then go about 30 degrees and slowly move away the sacrum and the central canal exit foramen. And then the needle in the joint sometimes help you to get the direction of the joint, and then you just put screws on either side. These are ala plates, so this is the pedicle screw, these are 2 ala screws, and these are done by Tim Pullman quite a long time ago. Okay, just a little bit of advertisement for the Singapore plate that we've done. It was a cadaveric radiographic study, and if you look into the IJO in 2012, it's outlined there in the technique. We did a cadaveric study and looking at the orientation of these screws, the iliac ala and the pedicle screws. And then we did radiographic studies to measure the length, what the usual screws length and sizes are. And then in this example of a sacral injury, initially fixed by external fixators, then finally we put in our wing plate and anterior screw. Reduction is quite good, and patient was quite stable. Initially, we did a lot of CT scans to see where the screw positions are, and we were quite happy that what we measured on the cadaveric and radiographic studies turned out quite well. So some steps about sacral injuries. Bowel prep, again, very important because you have to do this sometimes with the C-arm. But always delay about 7 to 10 days because sacrum, when you do laminectomies on the sacrum, stripping the sacrum, moving they tend to bleed a lot. They ooze a lot from the cancellous bone. And you have to certainly correct coagulopathy because otherwise you have skin problems with the hematoma. But don't wait too long. This is a patient who wait. When you turn her over to do something, you see this focus on the option. You have to remove the X-fix from the front for this because you're doing a prone position. And finally, decompress the abdomen. Again, the venous bleeding when you do sacral internal fixation. There are a lot of books that talk about doing midline incisions, but we put it on para-midline because the midline is this dorsal tips of the spinous process. And you can have we put our incision slightly to the side. And in this patient who had a very nice tattoo, we could actually match that quite nicely and the skin quite nice with no incidence of wound breakdown. Then the other way that spine people do it is strip from medial to lateral. We raise these flaps. These are all erector spinal flaps right to the tip of the sacrooccipital joint, raised up along the sides of the medium, and they are all pedicle, and you can now see all the foramen, the spinal process, lamina. Okay, then after you raise them, you can see a very nice it's a very fairly dry. I think 10 days old. You use nibblers to remove loose fragments, and sometimes the fragments may be around the foramen. Then you can use a laminar spreader to do your decompression, and you can actually look for the nerves going through the central to the lateral recess. This is the shape of the plate. We just bend it with a contouring, with a plate contourer, very low profile. Stays on the bone. These are the flaps easily. And then what we do is we put in our pedicle screws, alar screws, and then we have iliac screws. So there are 6 screws and 3 in the middle. So there's a 9-hole plate. When you finish, the flaps fall in nicely, totally covering the plate. And then you have a cushion for safety. And the incision is sealed off with subcutaneous sutures. A word about crescent fractures. You can see in this case a bilateral crescent fracture. This is a type 2. There are type 1 here, type 2 here, and type 4 here. And this is type 2 from Martin Bircher. If you cannot reduce, and often sometimes you see this, I think John's X-ray also showed something like this. You can't reduce this from the side. You have to go internally and pry this out. Push it, I think. So that involves an anterior approach, an ileoinguinal approach to reduce the fracture. This impact and then re-impact the fracture. And then you can put in your screws and your plates in 60-degree direction. And in this case, we incorporated all the way to the front, as you've seen in some of John's example. In some cases, you can go from the back because the front is already reduced. You want to do that, you can do it either by some plates on the side, but there's a lot of stripping of the iliac crest, and you can do percutaneous screw fixation from back to front, as I showed you before on the iliac screws from back to front. Finally, just a little word, which I don't do, I always get the spine people to do, lumbopelvic fixation, which means instrumentation running from the lower lumbar spine and with the rods going into the Galveston rods going into the pelvis. So this bilateral unstable fracture or H-shaped fractures, okay, communicator H-shaped fracture, jumpers, where there's hardly anything to put plates or screws on, bypass this totally, and you put in your Galveston rods technique and the pedicle screws in the spine. And here you can see the anterior ring in the pelvic ring. So the take-home messages are that the posterior ring must always, sometimes you miss them. You just do an anterior ring fixation, and then you find that there's some secondary displacement as the patient starts to do his rehabilitation. Okay, and if you do any posterior osteosynthesis, you will provide a lot of stability for resuscitation nursing and earlier rehabilitation program. But you must always have good intraoperative imaging. Okay, so having a good, not only a good machine that is reliable, but also a good radiographer. There are proper surgical avoid wound complications because the patient may not get out of bed after you do the fixation, so you may have wounds that may give rise to breakdown. Finally, you cannot be assured that neural injury can be avoided. So warn your patients of neural injuries when operating around the back of the pelvic wound. Thank you very much.
So, Coxon, that was great. Thank you very much. So we have time for some questions.
Yes, sir. So one thing which I want to ask about this one, sir, when you have told about the sacral dysmorphism, so in which case, sir, it is always open reduction, or we can try for percutaneous fixation after the.
I think the first thing to do is recognize it. Okay, yeah, because they may look. I have actually some cases where people put in the L4, iliac wing to L4, and the patient had a foot drop. So you have to count your numbers, and then but if you see dysmorphism, you identify the largest body to put in, because you really don't know. Okay, in this trauma situation, this is not something to do with elective surgery. So if you need to do a fixation, just use one screw in whichever is S1 or lumbarized L5. But lumbarized L5 has a lumbosacral trunk, so be careful that there's a foramen where the nerve can be safe instead of floating around. So generally, I try to do less fixation in the dysmorphism case.
Yeah, and also, so sometimes putting in the S1 screw would be almost impossible, or you can't put a very long screw. So you may have to go to S2 rather than S1.
Yes.
I mean, as we call, in reality, it is actually lumbarization. So you can say that the one you're putting is actually S1, but it's what you would count as S2 that you put in the screw. There's more space in that than in the S1. But there's one question from Dr. Gino asking, if the anterior fixation is strong and stable, is posterior fixation necessary in open book type pelvic injuries? I think we discussed this. Today, I think the general teaching is that it's always better to put in some posterior fixation as well. There are maybe situations where you feel the posterior injury is very minimal, where it may be adequate, but it's still, today putting in a sacroiliac screw is fairly straightforward and simple. So we would generally put in a sacroiliac screw as well. Coxon, you feel any differently or the same?
Yes, before we learned the proper technique or first started, we were very frightened of doing iliocecal screw. We used to put a lot of fixation in front. We put a single plate, then we put double plate, and then we put a double plate with an external fixation because we didn't dare to. But after we put in the two iliocecal screws, and they're like 7.3 or 7.0 screws, they were so strong, we now just go with one single anterior symphysis plate and one or two screws depending on the pressure.
Yeah. So one thing, Coxon, you didn't talk too much about is the anterior sacroiliac plating. I know you mentioned it in one case, but rather than a sacroiliac screw, are there situations where you would go for the two sort of divergent plates we put anteriorly in the SI joint?
Yes.
That's part of anterior fixation rather than posterior fixation.
I mean, it is a posterior ring.
Yeah.
Approach anteriorly. So crescent fractures or irreducible SI joint. If you can't get SI joint reduction, don't mess around trying to pull, and because the patient is supine, body weight alone can cause poor reduction. Just go in through the front. So you've done the phenostyle usually for the pubic rami plate. Just do a separate first window approach for the back. You don't have to join it up into a full window. And then from there, you use the far above clamps because you can get a better hold and fixation on the buttress, ischial buttress. And then you good reduction.
We need to reduce
it. And you can pull it out, you can push shunt screws. You can't get reduction, don't waste time. Just go in.
Yeah.
two plates. So the problem with the two plates is that they're very back. It looks very nice on the X-ray, but it's not easy to get the superior. There's a lot of curve between the ala and the posterior and the posterior iliac wing. So you have to have a really good exposure, and that's where the incision is a little bit further back. But the one in the front is quite easy. The one along the brim is quite easy. It's the one at the back, and you need to get at least one screw into the ala. Sometimes with the 3.5 plate, you can 2 screws without damaging the lumbosacral trunk, and then at least 3 or 4.
So again, your voice is, we're losing your voice a little bit. Yeah.
Sorry. Yeah.
Yeah. So I think, yeah, so you can only get one screw on the sacral side, and because otherwise you have the L5 root coming there. So don't try to put in 2 screws into the sacrum, 1 into the sacrum and 2 into the iliac, and 1 along the brim, and the other plate is usually at almost 90 degrees. It should be minimum 60 degrees for stability, ideally 90 degrees, but you have to mold that plate carefully because, as I said, it doesn't fit in so easily if you've not molded it adequately. So because you have a bump more superiorly, it's not as smooth as it is along the brim.
Correct.
So, one question asked from Dr. Ritesh from Maharashtra about the treatment of choice for lateral compression type 1 fracture.
So type 1 fracture, so it may actually be stable. Okay. So unless there's a reason for it being, to consider it unstable, or you want to get the patient up early because he's an elderly patient, those are fractures which you can treat conservatively. But if you have to fix it, it depends on the fracture. So the type 1 fracture usually will have a horizontal fracture and in the anterior part, in the ramus, and it will be an anterior crush of the sacrum. Okay, the classical type 1 LC1 type of injury. So often these are stable and don't always need to be fixed, but if you are planning it, you need to fix it according to the fracture. So you put a sacroiliac screw at the back and possibly a plate in the front if you are planning to fix it, or a percutaneous fixation of the pubic rami. Yeah, Coxon, anything?
Yeah, I agree. I believe you mean the type 1 is the fracture of the iliac wing that goes lateral to the SI joint.
LC1 in the Burgess classification usually means an anterior sacral fracture in the LC1. LC2 has the wing fracture.
Okay. So, yeah, usually they are impaction fractures. They are quite stable.
Yeah, impaction type of fractures, so they're often not unstable. So we have to see that.
So one thing what you have shown in your John sir in your PPT that you used to put a superior plate. Do we have to put one anterior plate also, sir? If we have a choice between these two, why not anterior plate, sir?
Because you get much longer screws in the superior plate, okay? So you get much longer screws. Anterior to posterior, you have only the thickness of the bone to go through, okay? So you'll get much smaller screws. So that is usually an additional plate if you think a second plate is necessary. Plus you need to do more dissection to get the plate anteriorly, okay? So you have to dissect more, and then sometimes your pudendal nerves, etc., may be at risk.
And so from where to where we can call it anterior ring? It involves acetabulum also, sir. So it is still ASIS or AIIS?
Sorry, I don't get your question.
Extent of the anterior ring, sir, when we call it like from where to where we can call it posterior ring, because
I don't think there's a definite line that, but I mean, acetabulum would be your point of reference.
Okay, sir. So acetabulum is in anterior part of the ring, sir, right?
Anything anterior to the acetabulum is anterior ring. Anything posterior, if you have an acetabulum fracture, then it's an acetabular fracture as well. Okay.
Yes, yeah. So it's the lateral part of the rami where it attaches to the acetabular wall. And that would be the end of the anterior ring.
If the acetabulum is actually also involved, the joint, then you would call it a pelvic plus acetabular fracture.
Sir, because when I was searching, sir, about the classification of the anterior ring, in one type of that is given by one Nakatani, sir, in that one, they involve the acetabulum in anterior ring because they classify it with that one. I was thinking.
It would be part of anterior column.
Okay, sir.
Okay, but if you're talking about pelvic, only pelvic injury, you would say that the acetabulum per se is not involved. But yes, you're right that some of these fractures will be extending into the acetabulum. Okay, and it will be still part of the anterior column of the acetabulum.
In case of open fracture, sir, when we have to fix the anterior ring, what is the choice for?
Open fractures.
Open fracture of pelvis, which is quite uncommon, but
No, it is. So here's where you have to decide between whether you would keep a fixator on for a bit longer, or you can do percutaneous fixation or open reduction and plating. So if you have gotten there before the surgeons have gone in and done a suprapubic, that's the best time to put your plate in. Once they've done the suprapubic cystostomy or whatever, then the risk of infection goes up, or a colostomy or something like that. Then your risk of infection goes up. So then you might prefer to put a X-fix or a percutaneous fixation rather than a plating.
Yeah, because sometimes these open injuries, rami are comminuted.
Yeah.
So because their rami are comminuted, it's not easy to reduce them. And also, if you put implants, they may communicate with the open wound, the thick, the screws, especially the longer screws. So I would agree to keep on an external fixator that is no implants in the wound.
And sir, when we have planned about the laparotomy, then what is the choice of our approach? We should go through that one, sir, to extending the incision, or when we are fixing the anterior ring, sir?
Yeah, so if they're doing a laparotomy and you need to fix the ilium, the anterior ring, so you have to rely on what approach they are using, okay? Yeah, so you can do a vertical approach and still do it if they're doing a rostrum. So ideally you want to get in there before they've done the colostomy, etc. So if it's not an open fracture, they're doing a laparotomy for some reason. So we discussed this, it's good to get, and they have a pelvic injury, it's good to have your external fixator on before they do the laparotomy, ideally. And then if you think your symphysis needs fixation, that may be the best time to do it as well, depending on how stable the patient is. If it's a very unstable patient, you just put on the external fixator, let them do their stuff and come back and do it later.
One of the problems of when they do these laparotomies and they got a lot of bleeding, the bowel tends to distend.
Yeah.
And they end up putting a zip back, a zipper. So when they put a zipper, everything is wide open. Then you have to think of, can I do percutaneous screw fixation if it's a rami fracture? Or you do a slightly separate the vertical midline incision of the surgeon with a little bit of a low Fenner field. Try to sneak in under the abdomen cavity. You are actually extra peritoneal. So you can try to get it done through a separate. You can do sort of an inverted T. It's quite safe in terms of wound healing. But because sometimes the belly is wide open, they don't want to do a primary closure. It's not easy.
Yeah. You have this concept of an anti-abdominal compression syndrome as well, yeah?
Oh, yes. Yeah. They're
worried about in these severe injuries where they would leave the abdomen open and put a sort of vac type of dressing on it and wait for the swelling to subside before doing the closure. So there, your wound will be wide open, and so you don't want your implants sticking out through those wounds.
And so when we consider external fixator for definitive fixation, so for how many weeks we can put it? Or we should take another type of Sanj screw, or is it same?
No, so I think, so the supraacetabular shank screws are very stable, okay? So you can keep them on longer if the pin site is very carefully looked after. So there you would, if you want to keep it longer, then it's good to put 2 supraacetabular pins on each side. Okay, there's space to put in one about a centimeter higher. However, that's something which you would do where for some reason you're not able to do internal fixation. It won't be your primary choice of fixation. Okay, so whatever reason, something like that, or where he's had some colostomy right there where you're going to do your incision, then you would, but then try and put in 2 supraacetabular pins on each side, and that will give you a very good stable fixation. But you still need to watch the pin sites very carefully, and you would leave your fixator on. Usually about 6 weeks is enough for the rami fractures to heal. The symphysis disruption is a little more unpredictable because
I usually put them on by the thing 6 or 8 weeks. The problem is the pins are in the groin, so these like often likely get discharging.
Yeah, so you have to really be careful about them.
So that's why the people have gone into the internal fixator.
Yeah.
So they converted the pins and brought it into the subcutaneous fat. And they put a bar across to make sure that there's no communication with the external element.
So that's the infix, like you do in the back, you can do it in the front, but in the front you have to be a little more careful about the structures.
Absolutely, yeah.
You have to keep the pin, the pedicle screw a little out. You don't put it all the way in the supraacetabular pin.
Yeah.
And there in a thin patient, it becomes prominent. So you have to be careful.
Okay, sir.
But either the clamps will either be under the skin or outside the skin.
Oh yeah, that's the other. If you put it outside the skin, then it's like an external fixator, except with a closer center to the thing. So
we use
locking plates as external fixators sometimes.
Yeah, in fact, people use this spinal instrumentation as an external fixator. The screws are better.
So one question from Kumar Gautam is that if we do conservative treatment for pubic rami, when to start weight bearing?
So the ideas of conservative treatment is that it's a stable fracture. Okay.
Yeah, you have explained.
So you want to start mobilizing them fairly soon. Even if it's not weight bearing, you would start getting them sitting and at least standing with a frame very soon. Yeah? Otherwise, it's better to fix them.
So for me, it's dictated by the patient's tolerance of pain.
Yeah.
Because sometimes they can be fairly painful. And the other thing that I find, instead of using a pelvic binder, you can use something like a sacrolock pelvic harness. It's a low sacrum, it's for people, those post-pregnancy, they have these belts.
Like a pelvic band or something.
Pelvic band, yeah, pelvic corset, in a way, very low. It's not a lumbar corset, it's below the waist. And
so we use that sometimes when they have this pubic, what is it? Osteitis pubis.
Yes.
During pregnancy, we've had patients with quite a wide dilatation of the symphysis post pregnancy.
Yeah.
So and sometimes it's very painful for a long time.
Yeah, that's the one to use.
So you are explaining about the infixer. So where is to put the infix? That is the same area, supraacetabular region.
Yeah, it is in the supraacetabular, more or less where you would put your external fixator pin, and in the same direction. The issue is that you need ideally long pedicle screws. Okay, so normally the spine guys use 45, 50. Here you need 70, 80, even longer, and ideally thicker. So they're not always available in the standard spine sets. Okay, especially if you want to keep them. Now you can use the infix as a temporary fixation or as a longer fixation. Usually they need to be removed. Okay.
So
at some stage, otherwise they'll break.
So even if we are using a pedicle screw, it should be little far from the bone, sir, so that there is space in between, because telling about the thinner patient, it is difficult to put. So means it
Because it
presses
becomes
over.
prominent, because if you put it all the way in, when you put your rod, it's going to compress on the femoral nerve, especially. And even the vessels sometimes, but femoral nerves are clearly compressed.
Okay, sir. Okay, sir. So I
Okay?
think, yeah.
I think we are, it's time now.
Yes, sir. So
It's
thank
pretty
you.
late in Singapore. So, okay, thanks a
It's
lot.
okay. I only have golf at 7 tomorrow.
Okay. You're back to playing golf, is it? That's
Oh, we
good.
are allowed to, if we keep 3 meters aside, away from everybody.
Okay, great.
So
Yeah.
thank you so much, sir. It
At
was
least,
really
now the numbers in India have come down quite a lot in the last couple
Quite a
of
lot, yes.
yesterday it was only around 85,000 or something. So
That's what it's going down.
hopefully, hopefully it remains in that direction. And we don't get a third wave soon. Okay, great. Thanks a lot, Coxon. And we'll
Thank
see
you. We'll see you next Monday. Yeah?
Monday. Okay, next week, Monday. Janki, you better let everyone know.
okay.
Okay.
Thank you
Okay.
so much, sir.
Thank you very much.